Dear friends, dear colleagues, welcome to the Mangano Digital Academy and welcome to the Essentials of Digital Dentistry. In this sixth video of the last series, we'll talk about the full digital workflow again. So the resolution of a very easy case, everyday case in our clinic by means of digital dentistry. Digital dentistry is based on 4 essential steps. The first step is the scan for data acquisition from real to virtual, CBCT, intraoral face scanner, digital condylography. Then we go into data elaboration through software for the planning phase, and after that we go back to real through the production of several things like surgical guides, crown bridges, orthodontic devices. Is the making phase. By means of milling unit, 3D printer, SLS, SLM technology, we can basically produce everything, and then we can clinically apply what we have produced. We can finalize the workflow, we can complete the workflow with the delivery of the surgical guide, the prosthetic restorations, the orthodontic device. Let's talk about a simple case treated through a full digital workflow. Once again, an implant prosthodontic case. We have this intraoral scan. We have this patient who want to receive a fixed restoration in the posterior mandible. On the left side, he would like to have 2 more crown there, and so we start with an intraoral scan with the CS3800 from Kestrel Dental. We can capture the master model obviously, but also the antagonist model and the bite, because it's important for the waxing, for the virtual waxing. This is the master model. We need to care about capturing all the tiles of the soft tissues and the neighboring teeth, and also the supporting teeth, because we need to think about the design of the surgical guide. So the scan must be complete and as accurate as possible. Then there's the beam computed tomography, and we have a pre-evaluation of the available amount of bone and the bone volume, the thickness, the bone height in the area, if there are still bone defects resulting from the extraction and everything. So it is a first fast pre-evaluation inside the beam computed tomography software, and then we can immediately go for the planning. The planning starts from a virtual waxing and the preparation of a model. The virtual waxing is realized usually in Exocad. The waxing is very important, and in order to have a good waxing we need to have the master model and the antagonist in perfect occlusion, because the waxing drives the treatment. It's a prosthetically driven treatment, implantology in this case. The emergent profile is based on the considerations, anatomical consideration, anatomical limit given by the waxing, by the virtual waxing and the wax up. And then we can import everything inside the computer-assisted design software for implant planning. In this case we use Mimics by Materialize. We have a DICOM reconstruction, so the 3D model of the bone, and this model has been already superimposed to several other things. Basically we superimpose onto the bone model the model of the intraoral scan and the waxing, the virtual waxing, in order to have the whole set of file, and then we can plan our implant. We will see our implant on the cross section, on the panorex, the position in all the different sections. It's important to control. The planning follows the superimposition, so the superimposition comes first. Now we have available software for example, artificial intelligence software like ReLU, helping us, because we can avoid to make this superimposition. We'll find all the file, all set of file already superimposed, but it's something that we will talk later in the next video. Here we see that we have to plan, and the implants are also in the system I use, HypnoGuide, connected with the scan bodies. It is extremely useful for eventually, in the case of, it's not the case, but eventually in the case of immediate loading. But it's also interesting to check the deviations between the planned implant and planned position of the implant and the actual position of the implant after the surgery. So this is what we have after all. 3D bone model, the scan bodies, the implant. This cylinder are the cylinder that will be integrated into the surgical guide. It is very important to evaluate everything step by step, and the cross section and transversal section are key, of course, to understand the position of the implant. The position of the implant at the end is a compromise. The position, the depth, the inclination of the implant are a compromise between the available bone volume and the indications given by the virtual walks and the walks up, the prosthetic walks up. Usually we tend to consider more the volume and then secondly the walks up, because we have a lot of components to correct eventually any inclination or excessive inclination. We can work with the prosthetic component, but the bone is the tone, in this case, and the prosthesis is the issue. As we can see here, the walks up and the implant position during the plan, and then the implant has been moved a little bit slightly, and the design of the surgical guide, the hypno guide in this case, is a metal sintered surgical guide, very thin, very elegant in the design. We can decide if to have this guide for an open flap surgery or for a flapless surgery. In this case we opted for an open flap, and the very nice thing of this surgical guide is that we can print 3 identical copies of this surgical guide. We will insert later some polyether ketone sleeves before the surgery, and then what the surgeon receives is a set of 3 guides identical in the titanium part. The only difference is the hole within the polyether ketone milled sleeve. The nice thing is that you can use your own drill, your own surgical kit, because these guides are already conceived in order to be adapted to your drill, so you don't have to care about any stop or any reducer to insert during the surgery. You don't need to care about nothing, just drill until the stop, and it's done. And as I told you, these are laser sintered guide in which we can place the lab, the service providing this guide, place inside this polyether ketone milled sleeve. So the surgeon receives the guide is already composite, a part in titanium, part in polyether ketone, part 3D printed and part is milled. The printer uses this Sysma MySint 100, and the service is provided by Arts and Technology engineer Matteo Bonaccina in Bergamo, Italy. And this is the preoperative picture of the patient. We of course go through a guided procedure with an open flap, and this is the preparation of the implant, of course, site by means of the guide, and these are the implants placed straight exactly as requested by the project. We prefer in this case not to place the implant through the guide, but manually, in order to keep the sensation of the bone quality. So it's not a fully guided surgery, it's a assisted guided surgery, because the last step, the placement of the implant, can be done manually without any guide, not through the guide. It's my decision, because I don't like the idea to have a contact between the guide and the surface of the implant. That is obviously a very valuable tool for the osseointegration, and we don't want to contaminate it in any way, in any possible way. Then after 1 month, 2 months, 2 weeks, depending by the case, depending by the indication, we can start the prosthetic phase. The implants here are any ridge by Megagen. Here are the scan body, 13 mm by any ridge. We can place the scan body. We scan the position of the implant. Obviously the scan starts with the capture of the antagonist, the master model after the removal of the healing abutment and the bite, and then later we copy the master model, we select the area of the scan body, we screw in the scan body. It is very important to screw them perfectly, and then we scan them. And after this we can have the different set of file, the master model with the mucosa collar, the scan bodies, the bite, everything is correctly in the position, and we can deliver everything to the dental technician. What comes back are individual hybrid abutment and provisionals. Everything fit very well. The individual abutment will remain there, so it's a 1 abutment, 1 time procedure. The prosthesis will be a cemented prosthesis. In this case we start with a PMMA milled prosthesis, or can be a 3D printed one. We can use several different materials for this procedure. but after a couple of months, usually of prosthetic load and adaptation to the load, we usually shift to the final restoration, in this case a monolithic zirconia bridge, a translucent monolithic zirconia bridge that, as we can see from the 1-year follow-up control, is still there. We always cement it temporarily using a 10-bond cement in order we can control the quality of the abutment, and as you can see, the soft tissue integration is quite good, no issues, functionally everything works very well, aesthetically satisfactory, and it's an easy case, ended entirely with a full digital workflow, and respecting the biology of the bone and the soft tissues, because the soft tissues love this individual hybrid abutment, and this is how it works. There's a perfect sealing of the soft tissues around the abutment is placed there, no longer removed, and then there is the restoration that is a final, monolithic zirconia bridge, perfectly integrated from the functional, aesthetic and biological point of view. This is an example of full digital workflow in daily dental practice. Thank you very much for your kind attention.